Welcome to this particular session on hygiene integration into various public health programs and policy. On behalf of WaterAid, Ministry of Health in Nepal, PRMSC from Pakistan, SightSavers, IFRC and UNICEF, I would like to welcome you all in this particular session. Altogether, we are going to spend almost 90 minutes together, now 85 minutes. So why we're here today? What we want to learn from this particular session is basically deepening our understanding on the importance and value addition of the hygiene integration into various public health programs. We also would like to understand some of the behavior-centric approach that has been used for integrating hygiene into various public health programs, whether hygiene into nutrition, hygiene into immunization, hygiene into public health emergencies or NTDs. We also understand the new knowledge and evidence on how integration can happen at scale. Also, the feasibility of integration at wider scale, and understand the current and future opportunities for integrated programming. So the flow of the session, after this welcome, I will go through a framing presentation. Just would like to highlight why integration is important. Followed by, there will be 4 case studies. I will call our distinguished panel colleagues one by one. One on hygiene integration into immunization from Nepal, hygiene integration into nutrition from Pakistan, hygiene integration into neglected tropical disease NTDs, and hygiene integration into cholera prevention and response. Followed by, we'll have panel discussion. Then we'll have a Mentimeter for audience engagement as well. So without further ado, now I would like to kick start just highlighting, kind of going through some of the framing discussion around why hygiene integration is important. What do we mean by actually integration? First of all, my name is Dr. Om Prasad Gautam. I am from WaterAid. I lead the hygiene behavior change portfolio at WaterAid. And WaterAid vision is a world where everyone everywhere has sustainable and safe water, sanitation and hygiene. What we have launched our new strategy. One of our strategic focus is on improving health. How we want to improve health is all about integrating WASH into public health program. We really want Ministry of Health realizing the importance of WASH and integrating WASH into their existing program. One of the key component is integrating hygiene into existing various program within that strategic aim. Because of that nature, we have been supporting multiple governments in different countries, and we thought that this is the right time for all of us, including WaterAid and all other actors working on integration together and reflect what we are actually learning from the integrated programming. This is why this particular session actually put in place. So hygiene integration, of course, as we all know here in the room, hygiene integration quite strongly fits within SDG 6.2 talks about educate and equitable sanitation and hygiene service for all, where at the same time, hygiene is foundational and fundamental for many public health outcomes and many sustainable development agenda. If hygiene is not there, its foundation is not, what happens? The sustainable development agenda collapse. Similar, the building that you can see might fall down. In this particular session, 3 terminology that we are going to use quite frequent. 1, hygiene, 2, behavior change, 3rd, integration. So what do we mean by hygiene for integration? For hygiene, of course, there are multiple definitions. If I start with from WHO, it's all about behavior that help to maintain health and prevent spread of disease. Then for WaterAid, we do have our own definition as well, because there is no standard sectoral definition for hygiene. So therefore we use WaterAid similar to WHO. It's all about good hygiene practices, it's all about behavior, but we want to make sure that behavior change is all about making people and their environment clean, and also talks about how behavior change improve dignity, increase productivity and the undernutrition. Then, because both the definition, as you can see, talks about behavior change, right? Behavior at the center. So what do you mean by behavior change? Behavior is all about what people do. It's not about what they think, it's not about what they believe to do, it's not about the process or skills, it's all about what people actually do. Third, here we are also talking about integration, right? So integration, what do we mean by hygiene integration? So integration meaning in this particular session is designing, implementing and evaluating an effective hygiene behavior change program through government-led existing public health programs, so whether this is immunization or nutrition or NTDs, and also integration, why? To maximize the benefit. Then also influencing decision makers to prioritize hygiene, part of their disease response, and also prevention for outbreak management. Here, 3 things you need to be very precise. 1, integration into public health, government-led, it has to be into the regular program, also emergency response. When we say hygiene, of course, there are different actors into the sector, whether they prioritize hand hygiene or multiple behaviors. But here, for integration, we're talking about multiple behaviors because multiple behaviors are important to block the multiple disease transmission route. Here, we are also talking about multiple settings, whether this is in households or communities or into the schools or healthcare facilities. And we target multiple behaviors, meaning, of course, hand hygiene is one of the standard primary behavior, but other behaviors including household water treatment, clean use of toilet, food hygiene management, menstrual hygiene management, waste management. But then when we respond pandemics or outbreaks, there are specific disease-specific behavior that we need to address. For example, when we were addressing COVID-19, hand hygiene was important, but at the same time, equally, wearing a mask was important. So we then prioritize disease-sensitive behavior to block the disease transmission. So if you are promoting any integrated program, you should be sensitive enough to target disease-sensitive behaviors. So therefore, we target that. In this particular the conference, you have been into the different sessions. I don't need to tell you where hygiene stands currently when it comes to global hygiene rates, for example, right? So this morning we had a JMP session. But one aspect that I would like to highlight from the integration angle is in every 2-second colleagues, a woman give a birth in a health center without adequate hygiene. Can you imagine a health workers touching a newborn baby just after a birth without washing hands? They are likely to be susceptible for infections. If health workers touch the baby, they are 3 times more likely to get the infections. And of course, you know, sepsis is one of the biggest killer among very young children. And many healthcare facilities around the world, almost 40% do not have hand washing facilities. So that means not having facility, meaning leading to prevalence of multiple diseases, including diarrhea. We know today, as we speak, diarrhea still kills 340,000 children, under 5 children, every year. And then, of course, if, let's say, those hospital-acquired infections are not treated, not managed, then what happens? We have resistance to bacteria, then that leads lots of consequences and severe death. So then, why hygiene integration into, why we target hygiene and why hygiene integration into multiple public health interventions? Because we know there are proven evidence that hygiene maximizes benefit. Hygiene can prevent disease. For example, washing hands can reduce diarrhea endemic by 30%. I think for this group, I don't need to tell, I don't need to go all of these statistics, but we know that there are proven evidence hygiene help reducing the prevalence of multiple disease. Not only the occurrence of the outbreaks and also dealing multiple diseases, but also it helps reducing transmission of the outbreaks, pathogens, and it prevents big epidemics as well. So for example, cholera or COVID-19 and so forth. There are multiple behaviors that has a established clear association, practicing those behaviors actually reducing disease burden. So because of this nature of hygiene, there are multiple public health programs demanding integration currently. Whether we are talking about nutrition, because the nutrition sector talks and Global Nutrition Initiative talks about promoting nutrition-sensitive intervention. WAS is one, hygiene is one of the key. Similarly, cholera roadmap, for example, in the plenary you have seen it, hygiene at the center, WAS at the center. Similarly, on immunization, for example, there is a global call for integrating hygiene for any enteric disease. Then similarly for NTDs, of course, the NTD strategy also talks about integrating hygiene for schistosomiasis, for trachoma, and so forth. Of course, there are other public health programs, whether it's AMR, the healthcare facilities. Many public health programs demand for integrated programming. For this particular session, we thought that would be nice to have 3 clear examples: hygiene integration into nutrition, NTD, cholera, and immunization. So therefore, in my framing, just another maybe 5 minutes or so, I just would like to highlight why hygiene integration into immunization. Colleagues, as we speak, diarrhea killing so much of children, right? In every 2 minutes, a single child dying from diarrhea. There is a global recommendation from WHO, UNICEF, that for enteric disease, including diarrhea or rota or cholera, we need to implement integrated programming. So therefore, there is a recommendation of having a protections, prevention, and treatment together. But we know when it comes to disease, people often think that vaccine is a silver bullet. If they inject, everything is going to be fine. But we know the nature of disease. Some of these vaccines are not 100% efficacious. But even if you vaccinate, the nature of disease, for example, the rotavirus is just 1/3 of the overall diarrhea. Even if you immunize, 100% of the children, only 20% children will be protected with the rotavirus. So that means the remaining 80% is still will be susceptible for diarrheal disease. So we want to make sure that people get the right information. So then in reality, how the integration happens, let's say if government is integrating hygiene into existing routine immunization program, what does that mean? If you have a young child, mother, take them in an immunization clinic within 1 year, multiple times, 5 to 7 times. How integration will happen? Every time they go, we want to expose them with the robust hygiene behaviors and intervention. So therefore, there is a multiple times we can expose them through the intervention. Is this happening? Yes, this is happening. The government of Nepal, with the support from WaterAid, modeling this program, it was done in pilot and subsequently now implementing at national scale. And you'll hear the case study after this presentation. The second integration is hygiene into nutrition programming. Of course, colleagues, as we speak, 4.7 million children die every year, out of which 2.4 million are dying due to undernutrition. And we know half of death among under children, 25% of the stunting cases are due to diarrhea, and diarrhea is cause and effect for both nutrition and diarrheal disease. We know once children start exposing with the contaminated hands or food, they start filtering the crop. So that means they're likely to ingest lots of contamination that will lead for helminths, diarrhea, environmental enteropathy, and cause poor nutritional status. So then, of course, nutrition sensitive program demands for integration. Is the integration happening? So what we expect for integration? Yes. If integration need to happen, we know there was a WAS benefit trial. They tried whether integration can actually maximize the benefit. One of the recommendations of the WAS benefit trial was we need a transformative WAS. So what kind of transformative WAS would actually lead for blocking the multiple disease transmission route? There is an example of government Punjab, PRMSC is actually implementing with the funding from World Bank. They are currently integrating more transformative WAS part of their ongoing nutrition programming. So we'll hear another case study from Pakistan in this presentation. Third, hygiene integration into public health emergencies. As we speak, colleagues, we have been experiencing so many pandemics, isn't it? Whether this was Black Death or cholera or Ebola or COVID-19, every time in any of these pandemics, hygiene was key line of defense. And COVID-19 was the 7th deadliest epidemic around the world, killed 7 million population. But then every time, any of these, whether this is Ebola or cholera or COVID-19, hygiene is first line of defense. I think we don't need to any other examples how we dealt. We all have seen it. And for this one particular example was WaterAid. Of course, we have implemented hygiene as key line of defense in multiple countries. We have responded. COVID-19 reached 242 million population. We have proved that it is possible to integrate hygiene into public health response, like in COVID-19. Of course, within these emergencies, cholera is one of the oldest disease, new approach. Everybody knows here. Of course, John Snow is being a founding father of modern epidemiology. People in the room knows John Snow because one of the key to track the root cause of the cholera when John Snow actually detected the cholera outbreak in London in 1854. And from then, since then, of course, the WAS sector, health sector, everybody knows that hygiene WAS intervention is identical in order to prevent the cholera. Do we need another epidemiological father to say this? No. It's all about how we actually prioritize and implement it. There is a cholera elimination or cholera control global guide, and everybody has to implement this in an integrated manner together with the OCB. The final one is why integration into neglected tropical disease. Of course, with the neglected tropical disease, there are 21 infections. Almost 1 billion people are affected by NTDs, and in 149 countries around the world. And we know transmission of trachoma, soil-transmitted helminths, or schistosomiasis is tightly linked with environmental contamination, and hygiene behavior change is one of the foundational preventive measures in order to reduce that. But then we need to understand the double link of WAS and NTDs. Because WAS prevents transmission, but at the same time, adequate water and hygiene conditions are essential for treatment and also disability and care. What is the recommendation? The prevention, treatment, care, management has to go together. Do we have any example? Yes, the SightSavers is actually integrating hygiene part of their ongoing program. We'll also hear from them how SightSavers is actually integrating hygiene to tackle with trachoma and schistosomiasis. So my final slide, this is how I'm going to conclude. What are we concluding from integration angle? Why hygiene is important? So what we need while integrating hygiene? So we need to focus on science and disease-sensitive hygiene behavior change program. We also need to integrate the integrated programming must demonstrate the mutual benefits. For example, if you are integrating with immunization, for example, the Ministry of Health won't agree just to integrate hygiene. If they see the benefits, integrating can maximize the potent benefits for immunization program and also hygiene, they will be ready for that. So we need to demonstrate that, and also integration needs to happen through the system, meaning that a system lens has to be part of the integrated campaign. Higher reach exposure for any behavior change campaign, the reach and intensity is quite important, that we need to maximize the reach, and focus on inclusivity and sustainability. Of course, that's the center of any program that we do. And for integrated programming, government should be at the center. Government leadership is vital, and they have to be into the driving seat for the integration. We will discuss more, because you will hear lots of examples on how integration happens in real life in a subsequent presentation. Sorry, I might have been a little rushed, because I know that we already lost 5 minutes, so therefore I wanted to pick my speed in 10 minutes delivering this. So hope I might have done some justice to the online colleagues. If you need any translation, that might be tricky. So with that note, now we want to move on. So the next presentation will be from Ministry of Health in Nepal. We have Dr. Vivek Kumar Lal. He is the director in the Family Welfare Division, Ministry of Health in Nepal. He is not only advocates, he actually drives the integrated programming in Nepal. He holds more than 20 years of clinical and public health expertise, and he's going to present hygiene integration into nationwide vaccination campaign. Over to you, Dr. Vivek.
Thank you, Dr. Om, for that nice introduction, and good afternoon, everyone. Thank you for being here. As he has already said, I'll be talking briefly about our experience of integrating hygiene behavior change in our routine immunization program. And to begin with, I'd like to say that our immunization program is the cornerstone of our public health program. It is one of the success stories, and we have achieved high coverages there. And we have around 17,000 immunization sessions that happen every month. Fortunately, still immunization has trust of the parents in country, and so we see that the parents come, as he has already shown in his slides, to ensure that their child gets all the vaccines that are part of the National Immunization Program. So our National Immunization Advisory Committee, which provides technical guidance to the program on introduction of vaccines, it had recommended for introduction of vaccines against enteric disease, but as part of that recommendation, they also said that hygiene promotion activities, behavior change, should be part of that vaccine introduction. So that built a strong case, but there was so many queries and I would say reservations before we could do this integration. And though our immunization program is doing well, we still have challenges in our nutrition, and we still have a significant proportion of morbidity and mortality from waterborne diseases, and so this is a very good platform, and I'll show you the results, and it just shows in this slide the current data on the malnutrition, status of incidence of diarrhea, and the status of WASH services as per the JNB 2024. So before we could move further on this recommendation, there were so many questions that were asked both by the health workers as well as program managers, like would it be effective, would it dilute the effectiveness of the immunization program, would it be beneficial, or it would somehow adversely affect the current program, would it be cost effective, and will it be feasible to scale up nationwide? Would it add to the capacity of the health workers and everybody else who is engaged in the immunization program? So to start off, we did a case study following a behavior change approach called, you know it perhaps better, that is behavior-centered design approach with 5 steps, A, B, C, D, E. And I always confuse them. A is to assess the current behavior and identify barriers to change. And B is build a solution that addresses the identified barriers. C, create a prototype of the solution. D, deliver the solution in the target audience. And finally, evaluate the effectiveness of the solution and make necessary adjustments. So with that, we launched our case study in 4 out of 77 districts of the country, and now it has been scaled up to all the 77 districts. So then we did a scoping study which gave us enough confidence that we should move ahead with a pilot and develop appropriate hygiene promotion intervention. And through formative research, we developed a package which prioritized 6 hygiene behaviors, of course including the routine immunization strengthening, exclusive breastfeeding, food hygiene, hand washing with soap, household water and milk treatment, hygienic use of toilet, and proper disposal of child feces. So this package was designed and implemented in 2015 and 16, and I will not go into the details, but it was targeting 35,000 mothers and guardians in the 4 pilot districts, and the parents would be reached out 5 to 7 times during a year during the immunization sessions. And it had different health behavior change components, including storytelling, games, folk songs, illustrative demonstrations, visual reminders, and several standardized tools were used. So before a session, when the mothers, it is usually the mothers and sometimes fathers as well who come with their children for the immunization sessions, and just before the session starts, for 30 to 45 minutes, the health worker and the female community health volunteers who were already trained would provide them the necessary information and help them adopt the hygiene integration into their regular behavior. So there is a very short video on...
This is Pramila and her son Mani. Pramila has been taking Mani to the health clinic in her local village in Nepal for vaccinations. At the same time, she's been learning about the importance of good hygiene. She washes her hands before feeding Mani and makes sure she properly reheats food. In Nepal, more than half of the population do not have access to a decent toilet. More than 1,200 children died from diarrhea in 2015. But things are beginning to change. The government of Nepal is integrating hygiene promotion into its routine immunization program. Female community health volunteers are empowering new parents to use good hygiene practices. This means the government can accelerate improvements in child health, reduce healthcare costs, and strengthen their economy for the future. Through an integrated approach, we can create a positive cycle for children like Mani so they can grow up strong and healthy and fulfill their potential. Act now. Coordinate, integrate, invest.
So that was the video that was made during the, thank you for reminding me of the time. So we also did, after the 1-year intervention or implementation, we did both a end-line as well as comparing it with the baseline information. And it shows that both, when it comes to the composite performance across all key behaviors that I had talked about earlier, there was a remarkable improvement. And not just that, it also shows that there was improvement in the coverage of the immunization and also reduction in the dropouts. So as you can see there on the graphs. And also in terms of building capacity of both the female community health volunteers and health workers, there was very good improvement. And we also did a cost assessment to see how much of additional resources would be required if we were to scale it. And the amount that would be required is $1.75 for nationwide integration. And in the on the right side, in the bars, you'd see the yellow colored portion is the proportion that is funded through government funds. And over time, from 10%, the proportion of support from government went up to 81%. And after the results were out from the pilot, the government took a policy decision to integrate it in as part of our routine immunization throughout the country, and it was scaled in 2020, and Now it is nationwide. More than 650,000 mothers or parents are reached out during those immunization sessions. And you can see Dr. Om there because he was very active there during this. And so we started with capacity building of all the health workers through a cascade down approach from training master trainers, then trainers, and so 27,000 health workers were trained over the during this nationwide launch. And we also designed different sessions based on the geographical location of those immunization sessions and also the number of parents or the children that would be entertained during those immunization sessions. And as I mentioned earlier, there would be different promotional activities including rituals, branded tokens, competitions, child life games, public commitments, and nudges. And similarly, for a high crowded area, it would be a 20-minute session. So I'll try to be brief and just now talk a bit about the integration, how it has happened. So it is now part of our routine immunization program, and the progress is reported into our routine health management information system. We have reviewed the national package and made it slimmer, and we have also developed a separate strategy to address the urban settings, and it has been happening throughout the country since 2020. And you'll see that most of the sessions are regularly conducted. Sometimes we have had challenges in ensuring that the necessary logistics is there on the place. And in 2025, we have done an evaluation, and it shows that the intervention has had a very positive effect overall in terms of improvement in knowledge, in terms of immunization coverage and reduction in the dropouts. And so I think the figures speak for themselves. And this would be my final slide where I'll talk a bit, I'll be summarizing that has already been covered here, that of course integration is feasible when it is led by the government, when it is integrated as part of the routine system, and opportunities for introduction of enteric vaccines that we did. We introduced rotavirus, then typhoid, and we've also had plans to introduce cholera in high endemic districts. So as part of all of those, we have been talking about that. And I think the leadership of the government and the kind of systematic approach we took from the pilot study to the studies and overall review and customization of the packages has been very important, and the continued support from partners has also helped us a lot in this process. So I'll again end by thanking everyone who were part of this journey, and thank you so much for your time.
Thank you, Dr. Vivek. I think this particular program shows how integration can happen and how integration can strengthen the system. This is what we are talking this afternoon, isn't it? One thing that Dr. Vivek did forget to mention, WaterAid, when we initiated this, we funded 90%. But then now, that was in 2015, and now government funds 90%. So he's the government here, right? This is how he actually turns it from pilot to national scale, leveraging government financing. And that was the question this afternoon posed to, I think, Claire, World Bank. If you were into the plenary, isn't it? This is one of the more. Colleagues, because of time, we should definitely need to move on. Now we have another great example from Pakistan. This particular project is Hygiene Integration into Nutrition Program. For this, we have colleagues from PRMSC. PRMSC is Punjab Rural Municipal Service Company, part of the Punjab government. We have Mr. Asadullah, he is the CEO and also the project director for this program. This project was funded by World Bank, and he leads this the big portfolio and one of the key actors into the sector. So, Mr. Asad Saab, over to you just to discuss about how integration is happening in Pakistan through nutrition.
Thank you, Dr. Om, and good afternoon, everyone. So I'm Asadullah, I'm heading the water utility. This utility is based in Pakistan, Punjab. The purpose of this water utility is to first implement the project, which is being funded by the World Bank and Government of Punjab, and also operate and maintain the infrastructure that comes out of this project. So to set the context, I have a small video, it was 1.5 minute video, so you have an idea what we're doing in Punjab, and then I'll explain why this was necessary.
If you click another time, it plays on. Yeah.
हमारे देहात हैं उसमें बहुत प्रॉब्लम है, लोगों को सीवेज का मसला है, पानी का मसला है, सफाई का मसला है और ड्रेनेज का मसला है। इंशाअल्लाह ताला पंजाब में 5 साल के बाद कोई गली ऐसी ना रहे जो टूटी हुई है, कोई जगह ऐसी ना रहे जहाँ पानी खड़ा है, कोई ऐसा शहर ना हो, कोई ऐसा गाँव ना हो जहाँ साफ पानी हम मुहैया ना कर सकें।
So the lady speaking in the video is our Chief Minister of Punjab. So what she was saying is that when she assumed the office, the first promise she made was within these 5 years in her tenure, she would make sure that every house will get tapped water and every street is clean and there are no open drains on the sides. This is what she meant. So I'm just summarizing it. So why integration necessary with nutrition? In Pakistan, there have been a lot of efforts in reducing poverty, and there have been a lot of nutrition programs in Pakistan. But despite those programs, there was diversity in dietary consumption, but stunting has been very high. So it has been 40%. 40% of our children are stunted in Pakistan, unfortunately, despite all the efforts we have made in the nutrition program. So the idea was that unless we provide clean drinking water and sanitation facilities to every citizen, there's no way we can reduce our stunting in Pakistan. So if we have a condition like this in areas in Pakistan, no matter what you take, what you eat, you're gonna get diseases, you're gonna get diarrhea and cholera, so there's no point. And then this was the reason why this intervention was necessary and this integration was necessary. So obviously, as I mentioned, in country context, there is high stunting rate, and then there was policy on the government of Punjab level as well that we have to integrate it, because the lessons were that without proper sanitation and water supply, you cannot reduce stunting. So big mix of both the prevailing conditions and then the policy environment that helped us to integrate this with the nutrition program. So this program, which we are implementing right now, is being funded by World Bank and also the Government of Punjab. 80% comes from as loans to the Government of Punjab, and 20% is co-financed by Government of Punjab. Punjab is a province in Pakistan. So the purpose is to provide safe drinking water and sanitation facilities to these to 2,000 villages in Punjab. So there are 24,000 villages. This is just the 10% of the scope we are covering through this project. And then we are targeting around 6 million people, 6.5 million people in 1 million households. So what our approach is? So we provide 24/7 WHO quality drinking water to each household. So we have laid the distribution network, pipe network. So from there we pump water out of the ground and we pump it into the overhead reservoir, and from there we send it to each household. And what we do is we also safely manage the fecal waste. Fecal waste is managed through the sewage network which we have laid in all these villages. So this is like these services are like a gold standard in wash that we are providing in rural areas. Although Pakistan is a poor country, but the government has decided that we are going to invest something now, and that has to sustain for the next 25 years. And then obviously, because this was being done for the first time in Pakistan, so we also decided that we need to change behavior of the people as well. So we cannot provide something and the people are not ready for it. So what we did, we integrated a behavior change capacity development program into this project. And the BCCD approach has been that we don't just go and start changing the behavior, we go in the field, we assess the conditions there, and then we do the formative research, and then theory of change, and then we create creative stuff, how are we going to change behavior of the people, and then we deliver, and then we evaluate as well. So this is door-to-door campaign, targeting 12 different behaviors, starting from hand washing to menstrual health to maternal child nutrition care, breastfeeding, and risk factors. So these 13 behaviors are targeted through different means and through 6 exposures. So door-to-door campaign, 6 exposures. So this is how we achieve the behavior change as well. So this was the baseline when we started the behavior change. So now end line is going to happen in November. So we'll see. We're hopeful that there will be a lot of changes in the behavior. And the only challenge is that this behavior should sustain the rest of the lives of the people living in these villages. So these are the key conclusions and the learnings. Obviously, when we started the pilot project, there was no really capacity of the contractors, of the consultants, or the design engineers. So through the project, the pilot project, we have implemented 200 villages. Through this, we have built capacity of both contractors and consultants. And then we have also seen that when you provide quality wash services, people are willing to pay. And in some of the villages where we have started supplying these services, people are paying the monthly fee, which is around $3 equivalent. And then another conclusion and the key learning is that because in Pakistan after the COVID there has been a lot of inflation. Because of inflation, things have gone really, prices of the material have gone really high. So we will face a funding gap. But for that, we have started tapping different sources of funding available to us. So there's a climate fund by, there's a facility, TCAF. This is managed by the World Bank. So what we are through this project, we are also reducing a lot of carbon emissions. So through that, we are tapping that as well, and our plan has been approved, and we expect to raise 40 million through that funding. And then obviously this is a very widespread project, so we believe that we need an IT-based solutions. We have developed IT-based solution where we track each and every activity of the project in real time through our MAS system. And then we believe that using that MAS system, we'll be scaling it up to the entire 2,000 villages. And then the good news is that the pilot was so successful that now the government has initiated another program, and based on the same concept, which is to cover another 500 villages, and that's been purely funded by the government of Punjab. And then obviously we saw that when we implemented this project, laying sewage network is very difficult in rural areas, because especially when the houses are not properly planned. So we are changing our methodology. We are using the open drains. We are covering it with a perforated slab, and we'll make sure that the fecal waste is managed as per the national and provincial environmental quality standards. Thank you so much.
Thank you so much, Asad sir. Excellent job, PRMSC, and of course, WaterAid was part of it for the behavior change component. Thank you very much, and good wishes for the second phase of the scaling up from 200 villages to 1,800 villages. It was one of the significant program funded by World Bank as well, and this was really transformative rather than very traditional toilets and TP taps. It's more of kind of meeting the WHO standards services. Moving on, colleagues, 2 more presentations, then we'll have some time, little relaxed, breathe in between. So then our next presentation will be on hygiene integration into neglected tropical disease. For that one, we have a colleague, our distinguished colleagues from SightSavers, Mr. Jody Wood, and he's a director of the social behavior change and WAS, and he will be presenting how hygiene can be integrated into various neglected tropical disease, including trachoma and schistosomiasis. Over to you, sir.
Thanks, Tom, and welcome everybody. I didn't get the memo. I got an awesome video, so you're going to have to, maybe I'll do a dance. And it's hard to follow up the really great work that's been presented. I guess, so my name is Jordy, and where I'd like to maybe start is, it's not lost to the folks in this room, is by recognizing that eliminating NTDs requires more than just medical interventions. It requires sort of a comprehensive approach that is cross-sectoral. So it's also not just WASH. And so I'm gonna kind of veer off from where we've talked, but present a framework that we co-designed with the Neglected Tropical Diseases Network and global group called BEST. And what WASH and public health needs, like a hole in the head is another acronym. But this is the framework that was developed to really identify what are the needs for control and elimination of NTDs. And it recognizes all of the components that are required for that. I think for this talk, I think the key insight here is how hygiene really cuts across all four of those components. When Owen presented the definition of hygiene, behavior was the first part. So behavior is the B. So behavior, that really spans across, access to toilet use, hand washing, face washing, things like that. But I also want it extends beyond that to the idea of collaborative institutional behavior. So collaboration and joining between different sectors, and that's a behavior that has to be changed. The second part is environment. And so an enabling environment, obviously, in order to have those hygiene behaviors, you have to have the enabling environment, which means construction, sanitation, and water facilities. And without that infrastructure, things like trachoma and other entities are just, for those of you who are in the preliminary session, there's no way we're going to eliminate those diseases without that. The S, I think, is a part that often gets left out. We've sort of touched on it, but that's social inclusion. And we really have to address equity in terms of reducing, controlling or eliminating NTDs. And that means ensuring that wash access is available to everybody. And also, as Alan presented for the NTDs, that it also means that there are services for treatment and care of people who are oftentimes affected by the burden of neglected tropical diseases. And then the T, again, is for treatment and care. So it's, obviously hygiene is really critical for good treatment and care of in this case, specifically NTDs. And so, again, I think this is a useful framework, but hygiene really ties through all four of those components. And sometimes I think, even certainly in the NTD world, we get very focused on the medications or the surgeries. So I think that it just really it shows how it's not confined to one sector, but it's really across the board. So now I want to talk about a couple of specific sort of cross-sector coordination and integration. Again, this is a little bit of a veer off because I'm going to talk about data. But in Nigeria, in 2019, 2020, there was an intersectorial group that met with the Federal Ministry of Health, the Ministry of Water Resources and Sanitation, UNICEF, the Bureau of Statistics, and a bunch of other folks. And they got together and they did a landscape analysis of what is the current snapshot of wash services and the prevalence of NTDs in Nigeria. And through this, the group combined a set of agreed indicators that from the NTDs that they could take to specifically the WASH MIS system and say, these are really, really important, and we can target better your interventions by targeting where the disease burden is in Nigeria. And so what you see here is this was launched in June of 2023. This is a combined indicators dashboard, and this is public facing. Anyone can go onto this website and log on, and you can scroll through. In this case, you can see soil transmitted helminths, looking at hand washing as a behavior, and in Aba State. And so you really are able to target specifically where these NTDs are. And so I think it's a really important part of this integration and beyond just specific hygiene program, but from a data perspective. In contrast to Nigeria, Nigeria had this great platform WashMs where we could integrate NTDs into WASH. In contrast, in Kenya, it was really difficult getting, sourcing the WASH indicators. As I think, I've had a number of conversations with folks today. It's oftentimes hard to access all of the WASH data. We've got the JMP, but that's such a culmination of lots of different indicators, and it's not at a district level. So in Kenya, we've integrated WASH data now into an NTDs database. So this is what you're looking at here is specific WASH data being integrated into the DHIS2 national platform for Kenya. And what's unique about Kenya is that actually a lot of this WASH data is actually also collected through specific entity surveys. So that's another way, and in those trachoma surveys we collect a lot of hygiene specific indicators. But I think the real winner here, perhaps, is this policy integration piece. Ethiopia was the first country to do this sort of concept of really merging NTDs and WASH data together. And while you could argue that the Ethiopia data that's currently still in that dashboard is really old now, it's 2018 data. But and we're really hoping to sort of update that. But where this led to, all these conversations led to a huge change in policy. So now NTDs are a criteria in the One Wash program selection. So through that advocacy and through this dashboard, they've actually changed policy based on integrating those data into the NTD system. So I think that's a huge win. Okay, I'm kind of all over the place here. So I want to talk about a couple of specific programs. Again, this happened a long time ago. In 2015, SightSavers partnered with Unilever, and Unilever had this, many may be familiar with this hand washing School of Five program. And what we did is we're like, I think we can integrate face washing into this hand washing program. So we integrated face washing into the Super School of Five program, and the program, for context, it's a lot like some of the other programs we've seen. It's interactive. It's based on creating solid habits, sort of like a public health prescription. There's games, there's comics, there are community leaders, school leaders. But there's some really good evidence that this works incredibly well. In Kenya, where we first rolled it out, we did an implementation. So we looked at, over the course of 12 months, and still at 20 months, we still had really, really significant change and continued practice of both hand and face washing behaviors, which I think is the important part here. And then, again, from that, it was scaled up into 5 other countries. And then the other sort of interesting part of that, in Nigeria, where we've not funded this for 3 years, in Kano State specifically, the Kano State Ministry of Education has adopted a version of this program into their programming. Okay, another part, and I know I'm running out of time here, but another platform that I think sort of from schools and that often gets missed in NTDs is for NTDs, a lot of the interventions are mass drug administrations. So many of you may know that. And one of the difficult parts of mass drug administration are the community drug distributor is really key to that. And motivation of that drug distributor, training, all of the things that go with community health workers is a big issue. And so what we created was the CDD passport. And the passport is exactly what it sounds like. It's a passport. But what it is it's a documentation of the training that they attended to do this mass drug administration activity. So it gives them all of the tools they need to do mass drug administration community. What we did is we added into that specific hygiene messaging for the MDA. So beyond just giving out drugs, similar to the Nepal example, this is a platform to include hygiene messaging into that platform. And I think, just going back, there's a lot of opportunities here beyond just NTDs. I think any community health worker having, a documented resource of informal healthcare workers or informal volunteers in the sector, so you know what training they have. And the new addition that we've added is this QR code. So that QR code makes it less bulky, but you can actually go to that, and the specific training you've taken, it will take you to those specific materials. So if you've done a training on schistosomiasis, it'll take you to the job aids for schistosomiasis. If you've done trachoma, and so on and so forth. So that is, hopefully more data to come, but that's what we're experimenting with this year. So, it was first rolled out in Chad, and from that experience, we've now got 5 countries that are testing this out. Okay, so my last points here are my implications and conclusions. So I think, that was really a whistle-stop tour of the NTD's intersection with hygiene. But I think that really, again, developing this multi-sectoral coordination piece is key, and making sure that we have dedicated budgets that are aligning with those multi-sectoral coordination. I mentioned the coordination of Ethiopia, etc. We actually funded 19 countries to do WASH and NTDs coordination. It's not sexy to fund meetings, and it takes a long time. But we have to align those budgets to be able to see some of these sustained changes. Again, the data systems is the other one, and then looking at examples from Nepal or the CDD MBA platforms, there are lots of places that we can integrate hygiene messaging. So thank you very much, and back over to you.
Thank you very much, John. Great. Thank you very much. An excellent example. I think you have seen into the plenary that the NTDs was one of the key areas where the sector actually talks about it, but really struggle to how to do it. But at the same time, there are lots of initiatives happening like this at a small scale that has to be replicated. And glad to hear, Jody, from Ethiopia and other countries, like there are national initiatives happening into these areas of work for integration. And good, with that note, colleagues, this will be last presentation, I'm sure. and then we'll have a lot of breath space in between. So our last presentation will be from IFRC. The IFRC colleagues is going to present on hygiene integration into public health emergency. Primarily, is going to focus on cholera. As you know, IFRC primarily support those cholera outbreaks in different countries. So for that one, we'll have Mr. Christopher Beer. He is the cholera lead, and he will be presenting online. Chris, can you hear us?
I can hear you. Can you hear me?
Oh, yes, we can hear you very well. Can you start presenting, please?
Okay. Thanks very much. Good afternoon, everybody, and greetings from Zimbabwe. Sorry I can't be there with you today. I'm the cholera coordinator for IFRC, and we work a lot in responding to cholera outbreaks. And as my line is a bit dodgy, I thought, first of all, I'm going to give you my 3 key ideas so that you would at least take those away if anything happens. So I think what I want to get across in this presentation is the idea that you have sort of different methodology for hygiene, as depending on the time you're in. If you're in an emergency or if you're outside of an emergency, you use different methods. Another key point is that outbreaks and responses are opportunities. They give us opportunities. And the third idea is that whilst we're in a response, we should perhaps be looking beyond the response so that we move from responding to what's happening now to put in place a more resilient community afterwards. Our responses have 3 main areas, so you can see them here on this slide. We do oral rehydration therapy. 80% of people can be treated with rehydration therapy. Then we do household and community level wash interventions, and this is the CATI, which I'm going to go into more detail in a moment. The other thing that we do is we support oral cholera vaccination campaigns. Next slide, please. Okay, so RC CATI is Red Cross, Red Crescent area targeted in limited resources in and immediate actions. I would say it's perhaps quite prescriptive and it's quite policed in the software. So what we're talking about here is, what we really need in a community where there is a case. We need to ensure that everybody is following these hygiene interventions, because that's the only way we're going to stop the transmission of the disease, which is what we're trying to do. The Red Cross, Red Crescent version of CATI builds on this a bit more to look at how we can extend this beyond the end of the outbreak into the medium term. Because we have permanent branches and we have a volunteer network in the communities, we have a good opportunity here. On the right-hand side of the slide here, this is the process they go through. So they work with the local health authorities to identify case areas. Where are the cases of cholera coming from, or suspected cholera coming from? The team then moves to that area and they work initially with the case households. So where the case came from. They're doing rapid assessments and then relevant disinfection and hygiene interventions. They then work outwards from the case households into the near neighborhood and then into the greater community, also looking for shared facilities. So for example, if the case household used a certain water source, then we need to move there and start working with the community and the rest of the people that use that water source. That could be our transmission point. And then the volunteers work with the community to identify actions that can be extended beyond the end of the outbreak. Next slide, please.
Chris, 3 minutes. Over to you.
Oh.
Are you still there, Chris?
Okay, so here is some time.
Sorry, Chris.
Of, here's an example of what we do. Just Côte d'Ivoire, where there's currently cholera outbreak. This photo was taken a couple of weeks ago, and it shows you sort of a hand people going onto the phone for washing hands. So what do we do? At household level, we are doing is most predominant in the first 7 to quick get to the household, be soiled clothing and bedding. Then we're ensuring water treatment and storage is water safe. So usually we chlorinate the water and we ensure that it's stored in, it's stored in a clean way. Then we're looking at clean and safe sanitations and disinfecting latrines and maybe making incremental improvements to them, such as a toilet hole cover. Then hand washing facilities, which we'll go into detail on in the next slide, preferably at household level, but also looking at shared spaces. And then also looking at food preparation and storage. Then what we're trying to do is move out into the community and the neighborhood. Okay, so we're looking at chlorination at water sources. We're looking at going to marketplaces and working with food vendors, working at schools, places of worship, and other community facilities. Next slide, please.
Thanks, thanks, Chris. If you could finish in 1 minute or so.
All right, so. Yeah, sure. This is my last slide. Yeah. Okay, so what we're doing in the long term, we're moving from sort of hygiene policing, if you like, to behavioural change, long term. In a response, you have an influx of tangible items, of training, of information. So we should be using this time when we get an influx of all these things to use these things to look at how can we make the communities more resilient. Okay, we have the experiential, this is very, their minds are very focused on this. Okay, so in the example of hand washing, we work with the community to identify barriers as to why can't you carry on hand washing beyond the end of this outbreak. And so they may come up with answers like, well, people just don't understand the importance of it, or we need somebody to manage public and neighborhood facilities. So what we need to do is we have to try and get volunteers to take on these roles, recruit our volunteers and get them to take on these roles. They might say, oh, no soap supply. Well, let's make sure then that during the response, we can make a stock of soap at the branch. They may talk about the proximity of the water source. It's too far to go to get water. But maybe during we have the funding to put in low-cost movement methods for different water. So small solar pumps, treadle pumps, ram pumps. For those of you that are wash geeks. Yeah. Okay, next slide, please.
That was the last one.
Okay, this is my final slide. Oh.
Yeah, I think we might have missed out.
Ah. Right.
That's the last slide here into the deck. Sorry. You want to sum up?
It.
Your internet is fluctuating.
Okay. But maybe if it was just a thank you for listening and sort of read more about what we do, and please contact me if you'd like to discuss more. Many thanks for your time. Thanks, Dr. Ram.
Thanks, Chris. Thanks very much. Sorry, I think if your last slide was just thank you. I think we haven't missed much. Thanks very much for joining from far away, talking about the IFRC response, on how you are dealing with the hygiene integration into cholera response. Thank you, colleagues. Thank you in the room as well, and thank you online. So those were the key examples on how hygiene has been integrated into multiple public health programs and policies. So after this, we have a panel discussion. So, but before we go for panel, is there any burning question to anyone? Is there any, or we just directly go into the panel? Yeah?
There might be some, there's a few in the chat. Look like
Oh, yeah, Chris, are you monitoring the chat into the, if there are any questions from the virtual audience, please? Are there any questions? Chris, can you actually start consolidating those, so as we move on, if there are specific questions we can address. With that note, let me invite now our colleagues from WaterAid, Ms. Sophie Eklins, and she is the Senior Policy Analyst at WaterAid, deals with on hygiene from policy side,
right.
and she will be facilitating the panel discussion. Over to you, Sophie.
Thanks, and thanks to all the presenters for those really inspiring, I think, case studies. The key things that stuck with me were that leadership commitment towards a wider vision in Pakistan from the video you showed, the national resource allocation and that impressive shift to 90% government funding in Nepal, and the absolute importance of strong data systems to enable decision making and targeting that you spoke about, Geordie. So, and all of that with these mutual benefits of integrated programming when implemented with strong partnerships but under government leadership. So it's my pleasure now to moderate a panel. I'm going to ask our colleagues who are on the panel to join us up the front here. The panel is going to look at digging a bit deeper into these driving factors, potential bottlenecks, and the roles of different actors in integrating hygiene into public health policy and programs. I'm not going to introduce all of the panel members who we've already heard from. I am going to just welcome Joanna Estevez Mills, who's a global public health expert and WASH specialist. But many of you will know Joanna from her leadership of the recently published WHO-UNICEF guidelines on hand hygiene in community settings. So welcome, Jo. So the panel members are going to bring us some diverse perspectives from policy and programme implementation, so we can look forward to some very practical discussions focused on what it takes to move from pilot programmes to sustain system-wide impact. So I'm going to start with a question to our government partners, Dr. Bibek and Mr. Assad. Thank you again for sharing your work with us here. Dr. Bibek, from your experience, what are the factors for transitioning from pilot programs to national scale implementation, and in particular, the factors that support sustainability?
And I think I should take out this. Thank you. I think in our context, what worked is that there was a systematic approach to collecting evidence, and over time it showed benefit not just in terms of resources but also strengthening the already existing immunization program. And we also did a cost assessment which showed that there was, if I may use the word, minimal additional resource that was required to maximize the benefit out of those sessions, that is in terms of improvement of overall hygiene behavior. And I think the approach that was taken was that it was integrated into already existing program. There was no new platform created, and government owned it from the beginning. And when it came to scaling up, I think COVID was a kind of a blessing in disguise, because everyone is already sensitized to the need of hygiene. So that helped, and that's how we were able to scale it up. But if it comes to sustainability, I see challenges ahead, frankly speaking, because In our context, the immunization program has a co-financing modality where government funds part of it and part of the vaccines and programmatic costs come through Gavi. But as we know now, Gavi would not be in a position to provide the support that it was. And also every year our co-financing liabilities increase. So, and my budget head has remained flat for so many years. So I do not know how, without getting additional support through domestic resources or outside, we will be able to maintain the same momentum. So that is a big challenge that I see. I hope I have answered it. Thank you.
Yeah, that's great. And as you say, COVID, I think, was really a blessing for hygiene, but it's that question of how do you then, I think that was probably worded wrongly. It wasn't a blessing, but a blessing in disguise is what I meant to you. So, but you know, how do you sustain that level of funding required to really continue the programs? Mr. Assad, we heard from you earlier that you're just completing the pilot phase, integrating hygiene behaviour change into nutrition. What do you see as the factors that will be important in Pakistan for transitioning from that pilot to the next phase of scaling in the coming months?
Thank you, Sophie. So you know, there was a reason for doing the pilot project because the government at the time when the project was approved, they said you just go ahead and implement 10% of the scope. And the reason was that, you know, this kind of intervention has never taken place in Pakistan before, especially in rural areas. So they just wanted to see what lessons are we going to learn out of it, and then see if we can actually go ahead with it. So the learnings we have, especially when it comes to capacity building of the contractors, consultants, and when it comes to using IT, and all those things which I shared as my learnings and the conclusions, they are going to be really important in helping us to scale up to the entire 2,000 villages. And obviously then the ownership of the government has to be there. Previously, you know, unfortunately, if this is the case in Pakistan, I don't know about other countries, whenever there are donor-funded projects in Pakistan, there's very little political ownership. Because most of these donor projects are just approved because the country needs dollars. So they just approve these projects without, you know, testing whether the interventions are going to work or not. So this was the case with this project as well. It was a very big undertaking, $550 million project, because when it was approved, at that time we had a very weak economic conditions, and we needed dollars. So we just approved the project. But the government was smart at that, and they said like, okay, we need dollars, but we are going to pilot it first and see if the results are encouraging, and see if the results, if we can actually learn the lessons and scale it up to the entire project. So those lessons we have learned, and we have been using those lessons in the design of the new, for the rest of the 1,800 villages. And obviously the use of technology we employed in the pilot phase, we'll be replicating it into our next phase as well. And finally, the ownership of the government has to be there, and the ownership of the government is there now, because the government has decided to find another project on the same lines. The same company is going to implement it, and that so that government ownership is also another factor for scaling it up. Thank you.
Brilliant, thank you. And I think that, you know, the government ownership, the building in the learning approach from the very beginning, and then like those system strengthening things around capacity and IT. Turning to you now, Joe. WHO and UNICEF just last week published the new guidelines on hand hygiene in community settings, which translate the evidence that we have into recommendations for public policy. Now that the guidelines are published, could you tell us how you anticipate them being translated into action through integration with related policies and programs, and what would be needed to ensure effectiveness of that?
Thanks, Sophie. So the guidelines were published just last week, a very big moment for us, and we're delighted to be here, so thank you for the invitation. Obviously, with the guidelines, we elevated hand hygiene as needed to happen, to shine a spotlight on something that has been repeatedly and persistently neglected, as we know. But now coming to implementation of those recommendations, it's really important that we think about how to do that in an integrated way, so that we don't encourage standalone sort of vertical hand hygiene programs. It wouldn't make any sense. It's one of a number of preventative measures that need to be implemented that have a number of health benefits. And the guidelines are really clear about that. The guidelines, I suppose, step back first and maybe talk about what the guidelines recommend before how we integrate delivery. So there's sort of 3 core requirements in the guidelines that we emphasise. One being the importance of minimal material requirements, so water, soap, the basics. I don't need to tell anyone in this room that that's critical. The second is around information and the importance of providing timely and accurate information to people about why to wash their hands, but how to wash their hands as well, and when. And the third core requirement is around a conducive environment, and that's both on the social aspects, in terms of social norms, but also in the physical aspects. So not just providing the basic material requirements, but also making sure that access is convenient, reliable. And so that's what in a nutshell, that's what the guidelines recommends. And how can we approach implementation of those really basic recommendations in an integrated way? Well, it's gratifying to listen to the colleagues today to see that there is so much happening already in this space that we as WHO would really like to listen and learn from and document as examples to inspire others in this space. I think some of the key things that I would say are essential for effective integration have already been demonstrated by the colleagues today. But firstly, not just looking at integrating health promotion messages and motivation messages, because those are really important, as we see in the immunisation example, they're really critical, but also integrating this importance of infrastructure and the availability of water supply and infrastructure, which is something we saw in the Punjab case and I think is really inspiring to see. So that's the first thing I'd say. The second is making sure that that integration is done in a really tangible way, and I think one of the examples that Geordie presented around data, hygiene data being integrated into dashboards was a really excellent example of that. We can't just play lip service to integration, we really do have to be very careful about how it's being monitored and measured, and specific budget lines, etc. And the third thing to say, I think that's really critical for integration, which is in a similar vein, is that we're paying close attention to oversight and coordinating across ministries, because hand hygiene does fall through the cracks, and doing it in an integrated way makes a lot of sense from an efficiency point of view. But there's also a risk in doing that we lose sight of lines of accountability and roles and responsibilities. So that was just my 3 points.
Thanks, Jo. And I think that those are great points, and they really tie nicely, as you said, in what we heard earlier, in terms of making sure that you have this enabling environment and being purposeful in integration, and the importance, of course, as you just said, of coordination. So I'm turning to our last panellists for this first round of questions, and then we might have time to open it up for 1 or 2 from the floor or from online. But Geordie and then, so maybe starting with Geordie and then Dr. Rom, based on your experiences, what do you see as the most effective roles that non-government organisations or CSOs can play in modelling integrated hygiene programming across various health initiatives?
Thanks. I mean, there's lots, but I think that similar to sort of the work that's been presented here is really that the proof of concept phase is really, and I think the IFRC example is really good. There's these huge networks of CSOs in lots of places all over the world, and sort of being able to take these small initiatives. You don't have to go immediately to scale in Nepal, but being able to have that as almost a testing ground through CSOs, and really having a place where you can fail fast, to sort of use a jargony term, but that's the way this works. Not all of these, integration sounds great on paper and it can be really efficient, but sometimes there are side effects, there are unintended consequences, and so making sure that you can kind of source those out. And I think that the role of CSOs in that is a really important one in terms of being able to really get the model right before going big. I'll stop there.
Thanks.
Great, thank you very much. I think, Sophie, if this question, okay. If this question was asked maybe to Dr. Vivek and Mr. Asad, how do you see the role of CSOs contributing to those great examples would have been the right answer. But I think let me frame this way. I think the technical support that we have been providing to the government in both Pakistan and to the Nepal since the beginning of these initiatives to create proof of concept intervention, like using a behavior-centric design approach, really using a science to inform the program, and also thinking and be ready to be placed as a technical partner. Because sometimes what happens being an CSO, advocating, doing a watchdog exercise related work, influencing government, but not literally being present on a day-to-day operation. For example, the Nepal case, when we started piloting these initiatives, we actually put our staff, WaterAid staff, within the ministry premises, and those staffs is still working with the government as a government colleagues, right? So ultimately what matters is how do CSO present themselves as one of the core technical partners to support to the government. One. The second, I think, Jody mentioned about proof of concept. Absolutely, I agree with you that. Third one, I think we should be ready about documenting learnings and also publishing it. One of the successful example for this particular one, Nepal, when initial study, the scoping study we have done, I think Yael might be online. Yael, myself, and Katie from London School, we actually went there. When I was at London School, it was like 2013. Right? So when we went to the Nepal, and ministry thinks that, oh, this has been the missed opportunity, but we have never done it. They were afraid of integration. So we published it in an international journal, then we started working with the government. So kind of, how do you actually document, offer more evidence for government to build that confidence is quite important. Creating policy environment is also important. I think as a CSO organizations, we always have the opportunity to influence government, creating more evidence, and also lobbying for government. How could we set a more enabling environment so that there is no policy gap or standards gap into the sector? We can lobby, we reinforce, and support government to change their policy. But at the same time, being a partner to operationalize those policies. I mean, of course, with the Pakistani example, I mean, one thing that I love with the PRMSC and also the World Bank is they were very much ready in terms of bringing science into this. So we use a behavior-centered design approach on how to design a very robust behavior change campaign that can fit well with the very much transformative WAS infrastructure. Because infrastructure often acts as a precondition, right? If there is no behavior change campaign, the utilization might be a problem. So we were ready. We were bringing that capacity elements to the government, to PRMSC, and to the operating partners to literally strengthen their competency to operationalize it. I think those were the key opportunity for CS when it comes to integration. Thank you.
Absolutely, and I think there was, what I heard from that was that flexibility that a CSO partner has to provide that proof of concept, but also the need for a close and strong technical partnership approach, and then of course the documenting and publishing, which helps inform policies. I don't know if there's is there any questions in the room, and we could ask also Chris if there's anything online, if you can hear us, Chris. Yeah,
I can hear you, yeah.
Chris, is there any, well, firstly, is there anything you want to add, even though you can't be here as a physical panel member, but, or are there any questions in the chat online?
No, not really.
Okay, well, we have one question in the room.
I can try and speak really loudly.
I think you probably need it for the participants on there.
Oh, okay.
Can you pass the mic on to it? Sorry. I can.
Okay.
Thank you for the great presentations today. I had a question for some of the case examples that were discussed about the political buy-in. So how did that take place, like conversion from WaterAid funding to Government of Nepal funding? Like how were you able to bring in those partners? Because it's not really a very, something that you can really present to the public to get votes, and that's specifically very important for the political parties. So how were you able to manage that? And if you could very briefly talk about that whole process, that would be great. Thank you.
That's a great question, and I think I'll put it to our government partners first, just 1 minute each.
Sure.
Yeah.
Thank you. That's a very tough question, if I may say so, because first and foremost, you have to be lucky. Otherwise, a lot of times you have very good evidence, you know it works, but if you do not have the political buy-in, you are not able to roll it out. But I think a lot of things worked in our favor, and first and foremost was the solid evidence base, and also the kind of acceptance we had, because it had, you could see that before national integration, the foundation was laid for almost 8 years, because in 2012, the Immunization Advisory Committee gave us this recommendation that it should be part of your vaccine introduction. Then there was piloting. Then we had the evidence. We sustained it for some years. And also, as I said, COVID was something which sensitized everybody. And one important part was the catalytic support we received from USAID. And that was also important, because even though you might have great ideas, if there is no funding to test it there, I think sometimes it's difficult for government to convince them to take up new interventions. So I think all of these factors work in our favor. That's what I would say. Would you like to add anything in your...
Mr. Assange, would you like to?
Yeah, that's very right. Actually, you know, when it comes to critical ownership, it's very difficult to build critical ownership. Because I remember because I'm lucky to be the project director for this project from day one. So when we started out with this project, they were like naysayers. They were saying like, you know, this system would not work. And even the sewage we are going to lay is going to get blocked, and there will be a lot of corruption, so many things, you know. But we kept on learning, and then the World Bank was there. They technically assisted us with the designs. They technically helped us with the design of these campaigns as well, behavior change campaigns. So what we did, we actually first built something and showed it to the government. So, and then there was also people saying that people are not going to pay for the services because there has not been any trend in Pakistan that people, even in urban areas, people don't like to pay for these water services. But we have proven everybody wrong with our pilot project. We have not only been able to generate demand notices, which means the connection fee for the water supply connection, but we have also been getting monthly bills from the villages. And this really motivated the government, and they saw the results. And when they saw the results, now they have decided, and the CM was saying that in 5 years, she wants every village in Punjab at least 24,000 total. So they have started another project, and then there is another project coming up. So the goal is to, in the next 5 years, cover each and every village where we would have integrated wash services, and then obviously behavior change campaign as well. And the important thing is that the utility I was I'm heading right now, is going to stay there forever. It's not just going to build the infrastructure and just leave. It's going to operate and maintain the infrastructure as well. So operation and maintenance is there. We have already solarized all our schemes. So major component of running these schemes is the electricity bills, and the electricity bills prices in Pakistan are very high. So what we did, we solarized them so that, you know, the schemes remain sustainable in future. So all these things helped us to build critical ownership along the way. Thank you.
Great. I think that, so echoing what both of you have said, just one additional point for Nepal specifically, I think this is going to be the same to Pakistan case, was government started seeing value for money of their investment. For example, when we started pilot in Nepal, it was costing $8 per target population. Then when we retained in 4 similar districts for another 4 years, it was costing $4. Then when we started going at national scale, it was only costing now 1.75. And then I think with the inflation, it went 2.65 something we presented. So I mean, but the government invests $40 per child for vaccination, and while integrating, we're adding 2.6. So the variation is huge. And hygiene has always been seen as cost-effective public health intervention. The government can see value for money, and it is not only helping improving the immunization coverage and behavior, but also it is also helping to reduce the stunting. You can see the diarrhea prevalence is going down. So we should be able to demonstrate the multifaceted contribution to multiple public health programs. That makes the government more accountable, and of course the policy decision was the key for both the country to actually for integration. Yes.
Thanks. So the question was around how do you secure political buy-in, and I think we heard very much the importance of evidence, including evidence beforehand to advocate for the program in the first place, but then also having an evidence approach where you're gathering that evidence, presenting back things such as value for money, the agility to leverage opportunities as they come up, innovation, and importantly, and it didn't come up before, but this long-term outlook. It did, Rome wasn't built in a day, but taking that long-term outlook. So with that, I think I'm handing over to you, Om, am I?
Yes, okay, so thank you very much. So you want to thank to the panel
Thank
and
you
then...
very much to the
Yes,
panel.
very good. So that I'm not snitching you. Great. Thank you, colleagues. Just 3-4 more minutes, if you allow us. So we want to go for a Mentimeter exercise because there are so many Mentimeter exercises if we don't do it in this session. So you might miss this session. So can you open your phone and scan this barcode, please? And colleagues online, so we are not ignoring. Please scan the barcode. Hopefully, I'm not sure whether that will be possible wherever you are. You can still, I think you can still use it, hopefully.
I think next year Mentimeter needs to be a sponsor of this conference.
Yes. Okay, so...
I'll let you talk and I'll navigate.
All this is already set up, right?
So hopefully,
the first question is around what are the multi-sectoral opportunities for hygiene integration? What kind of opportunity that you see for hygiene integration? We want to make it word cloud, so please type 1 or 2 words. Any opportunities?
we may have a Mentimeter fail here.
Did you set it up on your laptop?
Yeah, well, let's see.
You can only look on the actual laptop.
You can only look on the actual laptop. So I'm just interested in see if we can get.
You meant it too.
No.
Oh, okay.
For those of you online and in here, please do fill it out. We will we'll share everybody's responses, perhaps not live like we had intended, which is a bummer. But I think it would be really great to get people's answers to these 2 questions.
Sure.
Great. Yeah.
Okay, so opportunity, maybe 1 more minute if you could submit your answer. So the limitation here is we are not reporting you back. Seconds.
Oh, look at that. Okay, so we can read out some of the things that we're getting here.
That's very good. Great. ISBB vaccination, MNCH program include menstrual health, immunization, washing education, nutrition gain, every health programs, school market sources, collaboration with others, OPD service visits, lots of opportunities. Thank you very much, colleagues. Go to the next question. As you can see into the screen, if you could then highlight what are the key challenges for hygiene integration. What kind of challenges that you have heard and what you perceive where you actually operate. 1 or 2 challenges that you want to throw? Okay, great. We started hearing a lack of infrastructure, lack of informed social behavior change work, cost evidence, resources, practical level, awareness and funding, buy-in, finances, of course, is coming quite frequently. A lack of informed social behavior change work. Lack of products, yes, products for hygiene products are a precondition. Resources, links with financing, maybe human resource as well. Great. Yeah, I mean, look, I think as we are presenting lots of good case examples, there are lots of challenges that we need to face on as we move on. Thank you very much, colleagues. I think if you allow me 1 more minute, how I'm going to sum up this particular session is, of course, integration is fundamental. As you have been seeing throughout the presentation, integration should be integral. So for that one, what is necessity? What are the key factors that lead for integration? One we have been hearing is the government leadership is vital. Let's work with the government. We need to demonstrate mutual benefits for both the programs. For any entry points, any public health program that we're thinking of integration, the hygiene should mutually benefit both behavior change and also their program. Leveraging financing is key. Don't often think that the funding is always going to come from your end. How are you going to leverage government existing financing through the existing program? This is what exactly we have heard. Data is important, therefore work with the government. How do you actually institutionalize, work with the government, including the indicators part of the HMIS or MIS systems and so forth. Standard guidelines are important, as Joe was also mentioning. I think whether this is a global guidelines or national guidelines or standards, the countries are developing roadmaps and so forth, those need to be there so that at least there is a standard program all across multiple geographic locations. Behavior-centric approach is important, I think in both the case in Nepal and Pakistan, because we were very much evidence-led, because we didn't want to just put a kind of very cognitive knowledge-focused intervention. We were behavior-centric and kind of modeling that program that works. System-focused intervention, I think integration always has to be system-led, that was evident. And finally, for behavior change, preconditions are also important, which is infrastructure, and we should be very much agile and also very much open to leverage existing water sector financing or government financing in terms of securing the infrastructure in order to inform or in order to facilitate the behavior to happen on the ground. So those are the key points I think from this session. With this note, thank you everyone, all the presenters, especially the colleagues from the Ministry of Health and also colleagues from the PRMSC. Your presence here is excellent, and thank you very much for making your time all the way from those countries. And other colleagues, Jody from SightSavers, Chris from IFRC, thanks Sophie for facilitating the panel. Joe, thank you very much for joining into this panel, and everyone, colleagues online and colleagues in person, thank you very much for your time.
Panel, that's why I hadn't released.
Could
you go and sit back and pretend you're paneling again? That's